3, 2, 1. Needle
Needle
pod.
pod. Hey, I think that was our best one.
We almost harmonized for a moment, and that was unplanned as usual. This is your first episode. That's how we awkwardly kick off every episode. So welcome to the show. Paul Kaloran here with Ellie Melrose, which if you're watching this on YouTube, Ellie, not to call you out, but did you type in your name as Merlose? Can you see
Oh,
that the
I
bottom of
see that that is wrong. Yeah, no,
Ellis,
I didn't.
Dr. Ellison
It was
Melrose?
Merlot. It just auto pulled in, so I must have typed that another time. So,
Hmm.
yep, that's
I like
wrong.
it. I like it. But
Yeah.
so today we're talking dry needling skepticism. And I mean, I'm going to tee this up different ways, but whether it's worthwhile or worthless, I frequently get pulled into the Twitter battles and the Instagram battles. And, sometimes it's dry needling versus acupuncture. Sometimes it's in our profession, people that, are fans of needling or not fans of needling. I guess normally it's people not fans of needling that I jump in like Robin Hood to defend just the dry needling stance. And it happened recently. So I think just what we have to admit is even on the clinical side, on the professional side, not everybody is a fan of needling. And when I say that, that ranges from pretty neutral, just like, yeah, maybe it's effective, maybe it's not, but I don't use it, to strongly adverse. There's too much risk. There's no evidence. There's no reason why I should be doing it. In fact, if you want to add the Instagram flair, it's like, you're dumb if you think needling is worthwhile or if you're poking your patients because there's no evidence for it. So there's that side of it, and that's where I want to go first, Ellie. And then
Mhm.
I want to kind of bring the skeptical eye to the patient view, just admitting that not every patient wants to try needling. But let's start with that first persona. So Ellie, I'm sure you've heard it
Yeah.
before on courses or just in our professional arena. They know that you needle, they know that you teach needling, and you get the scoffing laugh, you get the eyeballs, you get the piercing questions. Just teeing it up for you, how do you have those conversations?
Yeah, well, I think when you look at like the why behind their questioning, there's typically a couple different reasons why people will like criticize or demonize dry needling. And one is like they argue that it's, no better than something else that we do in our profession. Like it's more of a placebo effect. Like if people have this
Yeah.
positive expectation of it, then they will see the benefits of it. And then following that is like the evidence and the research doesn't support maybe how we're using it clinically. And then also, I think another criticism is that people rely really heavily on needling instead of all of our other tools in our toolbox, like, pain neuroscience education and exercise and all of those other things that, from a clinical perspective and a research perspective, there is a little bit stronger research there in the benefits of exercise in our profession, right? And so I think the biggest thing that we have to remember is that like the first thing when it comes to research and acknowledging the research, our profession is continuously evolving. Like where we were 15 years ago when you were entering this profession.
Yeah, thanks for that. Thanks for that. The land
And
before time. Thank you.
and for me, it was 9 years ago when I was entering the profession, right?
You're not a new grad anymore.
I'm not, no. The landscape has changed, and a lot of what we've seen in our practice, it's like, okay, we try it first, and then research gets done, and then we realize the effects of it. And we saw that with manual therapy, right? Like when I was in school, it was still pretty like mobilization heavy. My doctoral program had a little bias against spinal manipulation. And so we didn't get a lot of education in that space. And we know
Yeah.
that it is super beneficial, even from a research standpoint. And so that's something that we have to remember is that everything we do is always going to have this like 3-step process where we're starting to integrate it. Then we start to do the research and then we start to see how it's actually clinically effective. And I think that's kind of where we are in dry needling because how it's evolved. Like it came from a like physician driven practice, and utilizing needles in different ways and figuring out what the effect is on the nervous system or I mean, at that point, it was more like trigger point stuff, like, or what are we doing localized to the tissue? And it's evolved from there. And yes, there's also a big, like, not that I don't want to compare acupuncture to dry needling. That's not the point of this conversation, but they've been doing acupuncture for lot longer than we've been doing dry needling. And there's research to support that. And there is research to support dry needling. But if you look at the past 5 years from the research perspective, that's where we're seeing this big boom in dry needling research. And in a pelvic space, especially, like a lot of what I talk about in my course, the newest research is from last year or 2 years ago. And so
Yeah.
I think that's
Similar
something.
on the e-stim front.
Yeah, yeah, definitely. And so just because the research isn't, I think the biggest thing is research isn't standardized. Like we don't have a this is what's always going to work for that, right? It's just like anything else, we do a little bit of clinical experimentation. And do
Yeah.
things change clinically versus do they change on a randomized control trials level? And we've seen it both, but if we're not using that, the clinical experience and the clinical experimentation and seeing things on a n equals one level, then we're never going to get that research going forward,
Yeah,
you
I
know?
hear what you're saying, and it's true. And unfortunately, in these like intra-professional evidence debates or
Mhm.
discussions, the N of one empirical anecdotal is immediately dismissed as no value. But it's
Right.
true. That's where we all started. Honestly, thank you for acknowledging how long I've been here. But back in the day, people were taking dry needling courses not because it was mainstream physical therapy. It wasn't even in every state, and there was not a large research data set with well done clinical trials and systematic reviews and meta analyses. It was just people showing up saying, I had a colleague that was needling in the clinic, and just the results they're getting are incredible. Or I took one course and just kind of started using it on a very small percentage of people, and it was doing different stuff. So, again, I'm acknowledging both sides of the fence. That is the lowest tier of evidence. We can't hang our hat clinically professionally on what people think based on small personal sample sizes, but that's where it started for sure. I would argue that was the conversation I was having a decade ago. And what you
Mhm.
just said is true, is that no longer do I just have to say, man, this has helped a lot of my people. And man, didn't you read that really cool case series where they did it on 10 folks and it helped? We now have better data. We now have well
Mhm.
done clinical trials. We have systematic reviews in pain, like in top journals and meta analyses, but we're still hearing the folks. I mean, the Instagram discussion that I had last week was based off of someone basically still criticizing dry needling based off of the 2025 hip arthritis CPG, the clinical not
Practice guidelines.
I was going to say, I always think that the CPR versus the CPG, but yeah, the practice guidelines, which lists dry needling as a grade A intervention. And I mean, if we're talking through that textbook tier of research, systematic review, meta-analyses, I mean, CPGs are supposed to be that unbiased, that assimilation of all of the lower level of research. And basically, does that put it at grade A, grade B, grade C, grade F, or not even listed? It's listed as a grade A intervention. And this guy, I won't name his name, but I mean bigger following than I do, was still saying, "Yeah, I don't really like dry needling, and it's listed as a grade A intervention for a hip OA CPG, but you know, a lot of those RCTs are not really well done," which you can argue for anything. So I said what I said, but I sit back in my chair and I bring it up on this podcast because I'll ask you a question I've been asking myself this past week, but honestly for the past years and 10 years. Will there ever be a perfectly done study, a perfectly done double-blinded randomized controlled trial, or will dry needling ever have the perfect systematic review or meta-analysis where guys like this, who's in our profession, he's a physical therapist, are going to turn course and say, you know what, I was wrong about needling. Maybe back in the day we didn't have the evidence, but now we have the evidence. Do you think we're ever going to reach a tier or have the perfectly conducted thing that makes
I don't know. I mean, that's the thing. It's like maybe
there's
not.
no answer, but I
Yeah.
want to know your thoughts anyways.
Maybe not, and even so, it's our profession from like, I like to also think about the research that we do is the reason why randomized can like okay, how do I wanna articulate this? When you look at randomized control trials, they are trying to isolate individual treatment styles, right? Like dry needling versus exercise, or dry
Yeah.
needling versus manual therapy, or dry needling
In a
versus something
silo.
else
Yep.
in a silo. And that's not how we practice. And so
Totally.
even if there was this like huge randomized control trial, like you said, double blinded, blah, 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 like, and they found benefits or they didn't find benefits, that's not how we apply it in the clinic. And I think that's another like big thing of what we need to take away from this is that all the tools we have in our toolbox are just that. They're individual tools. And when you're going to plant a garden, you wouldn't just use a shovel, right? You would till the garden, you would shovel, you would add water, you would do all these other things to make that garden flourish. And I think that's the same thing that we can think about from a physical therapy perspective. So even if we did get that randomized controlled trial, and even if it said positive things about dry needling alone, that's not going to be how we practice it clinically. And I think that's also a downside with what we're seeing in the clinic is that clinicians have so much variability in how they utilize dry needling from their like education, and it's evolved over time. And then also, as I mentioned, with the common criticisms is that people overuse dry needling. And I'm coming from a dry needling educator perspective, I'm saying that I think people use it too much or they use it without adding in other things. And so I mean, I would love to see a handful of randomized control trials that are evaluating exactly how we do it, right? But the likelihood of that happening is, again, I don't know, slim, maybe.
Yeah.
That
And I mean, you just created the perfect segue for the patient skepticism. But before we go there, unfortunately, I agree with you to my own question, my own musings of I don't think there's ever going to be unanimous agreement, whether it's research based or not. And unfortunately, that's because even manual therapy is still having conversations like this. And honestly, exercise, which is the most universally accepted, most beneficial, low risk thing we have, there's still debate in our profession about how aggressive we can be, how heavy we can be. So maybe these conversations they feel closer to home to me because they're regarding dry needling, but it's a natural course of evidence, research in general, but just interprofessional variability, like you said. And I do want to jump to that second persona because there are patients that are skeptical. And
mm.
my first question to you, because yeah, you needle a lot, you've been needling a lot for years. Do you find that those skeptical patients are the ones that are like, oh, I've never heard of dry needling before. I'm a little nervous about it. So basically blank canvas, no experience, but like, yeah, I'm a little nervous about that option. Or is it the other one, which is, oh yeah, I've had that before. And to your point, maybe it was like the dry needling that we're planning to do, maybe it wasn't. They're like, ooh, yeah, lots of needles, really sore, didn't like it. It either didn't help at all or it kind of made me sore, made it worse. So
hmm
what drives the patient skepticism the most? Is it blank slate neutral needle aversion or is it previous experience?
I would say it's more previous experience, negative previous experience. And because I think how I've evolved my education around needling, it's just like another tool like cupping or something else. And if they do have discomfort with needling or like an aversion to needling or a phobia or something, it's not necessarily the first place I start. One thing I talk about on our courses is like our profession is so cool. We have so many tools that we can utilize, and dry needling is just one of them. And that's not where we have to start with everybody. But I educate them about it on that first session or second session when I'm wanting to try and implement it. I let them think about it, and if we're not seeing results that we want to see clinically, at least maybe as efficiently as we want to, I always will remind them that we have this alternative treatment or this other treatment that can be effective. And I'll usually say something like, so this is for the folks that have never had it before. It's like, give me one session, let's trial it. We're going to do as little as possible, as much as I think is necessary. And if we hate it, we never have to do it again. And that's okay. Right. And then from the other side of the coin of folks that have had needling experience and it's been a negative experience, I will dive a little bit deeper into what was negative about it. What was their perception of, were they sore after it? Was it they didn't see any change in the symptoms? And so I think there's two different conversations with that. With the folks that had so much soreness that it was not worth it for them, I'll say like I'll ask how they've had needling before, if it was, they just left needles in, or if they did some pistoning, or if they did e-stim. I'll say, I might needle a little bit differently than how you've done it in the past. And I want you to be open minded to that. And again, it's not maybe I'm not forcing them within session to make that decision. I'm having that conversation and opening that door a little bit. And then again, revisiting it on follow up sessions and be like, let's try it. I might do something a little bit different than how you've had it in the past. Give me a session or two of trialing it. And if you see that it's helpful, then we'll continue to work in that way. I also think with those folks, you have to show them in-session changes, like
Totally.
not just a symptom reduction. And you have to set them up for what to expect following the needling. Like you might be sore for the next 24 hours or so. It might feel like your muscles did a little bit of a workout, and that's okay. Here's some strategies, here's some exercises that can help mitigate that versus just sending our folks off after needling and being like, all right, let me know how you feel. We have to look at the objective measures pre and post treatment to show them the improvement that we can see. And then that little bit of post treatment soreness is not that big of a deal for them,
Yeah.
especially when you layer in the e-stim. The e-stim, the exercise afterwards really helps to kind of mitigate that post treatment soreness. And so I think that's the the one side of it. Um, and then honestly, I can't remember what my other side. I probably like wrap them into the two, but
Well, no, you're saying a lot. And to summarize, because it was well said. First of all, I agree. I mean, even if people have a needle fear or aversion, let's say they want to try the other strategies first, the manual therapy, the more conservative movement based stuff. When they get to the point of considering an injection or surgery or
mhm,
pharmaceuticals, they're fine with the needle. So rarely is it, I'm trying to think of like real patients in my head, rarely is it people coming in with a hard stop sign saying, don't ever mention dry needling again because I hate needles. It's typically what you're saying is don't talk about dry needling again because my last PT did it and it felt like this. And that's the
mhm,
more nuanced conversation that you went into. What's funny is you made me think is, we're jumping from like the research conversation with a colleague to now a patient. What I've never heard a patient say is, you know what, Paul, I don't want to try dry needling because I did it before and it made me feel great for a week, but it didn't give
mhm,
me 6 weeks of like, no patient says, man, I felt great for a week or two, but I need that thing that, by itself is going to give me 6 weeks of feeling great. No. If a patient felt better for a week or 2 weeks, they're like, for sure, let's try that again. But just letting you know, I've had this before and I'm still coming to see you for that knee thing, that plantar fasciitis. That short term benefit is of value to a patient. Like on the
mhm,
research side, it's seen as a negative, like oh, only 1 week at 2 week, 4 week, 6 week follow up, the diminishing returns were not there. It was the same as everything else. Patients want that 1 or 2 week feel good thing. Like
mhm,
they're getting massages, they're doing percussion guns, they're doing the things that make them feel better quickly and for a short period. And then the conversation shifts to like, you know what? It sounds like the dry needling it's doing its job. We either need to treat something else, being maybe we're not treating the root cause, or we need to reinforce those short-term changes better. But I
yeah.
mean, it's interesting that the short-termness, I've never had an athlete stop seeing me. And these are people paying cash. They're like, "You know what? I only feel great for a week or 2 after our session." So,
No,
I
they say, "I feel great for a week or 2 after
yeah,
our session." It's like,
should
it's the same
I
thing.
see you more often? That's what they're
Yeah.
saying. And still the answer is, "No, I think the needling's doing its job. I think we need to find out what to do after the needling to make it last more than a week or 2."
Exactly, and that's the thing, and that's what we talk about in our courses is, like, dry needling creates this window of opportunity. It's not going to completely I mean, some people, it's crazy, it's like, never have pain after that one session of dry needling. Not everyone's like that, and it's because, 1, pain is more nuanced than just, "We have an issue here," right? But also because, like, yeah, we need to re-educate that tissue or that the cortex that this movement or this joint is safe. And how we do that is with our other tools, is with exercise, is with graded exposure, is with pain science education. And so yeah, so we create this window of opportunity from a pain perspective, and then also these windows of opportunity for changing things like force output and range of motion in the joint and resting tone, all of those things. But it's not a long term change. And I think if you have to be the provider that educates them on that versus saying that this is going to fix everything. So
For sure.
yeah,
Love it.
yeah,
And
yeah.
we're at our time. I know you have a patient coming up. So if I'm allowed to summarize, I mean, if you're
Mhm.
new to needling or considering adding needling, first of all, I would expect at some point to have a conversation with a colleague that doesn't confirm your biases. Like in fact, there's probably going to be some friction there. So I would get comfortable having those discussions. And I guess what I should say is you should have those discussions. Don't just be a closed door to anybody that debates research or has questions on the efficacy. Like we need to have those conversations for sure. And also be prepared for the patient skepticism or cynicism and whether they come to you with the stance that we're not going to use needling at all, or maybe it's not the first line intervention that we're recommending. I think we just have to be comfortable with those conversations.
Totally. I love it. That was
All right,
fun.
so much fun.
Yeah, where can people find you, Paul?
Uh, if you're on the socials, I guess at DPT with needles, all spelt out. If you're on the ICE app, I mean, it's just like social media. So there's a dry needling chat. You can DM me directly. How about you?
Uh, at Ellison_Melrose, not
Merlots.
Merlots. Yeah, that's where I am. I respond to DMs there. And then, like you said, I respond to the chats and direct messages on the app. So happy to
Hell
answer
yeah.
any questions you have.
Thanks for tuning in. We'll catch you next time. If there are more questions created from this, you can hit us up on those socials, which includes YouTube. We do put these videos, even though you're probably listening to this on Spotify or wherever you listen to your pods. But this has been the Needle Pod. We'll catch you next time. Thanks for listening, crew.